over time. And it does look like tumor, not just post-operative changes. So
Okay.
taking it out may cause more problems. So they decided it was a good time to try to do radiation and see how much of it can shrink and then over time. So these are his scans. I just wanted to show you that the tumor really has grown from September last year, which was his, I think, the first one after he completed his surgery, right?
Yes.
So, alright, then let's see the most recent one from last week. Alright. So these are pictures of you kind of lying on a couch here, head inside, feet sticking outside. We are looking at your head from the bottom. So these are your eyes in the front, left side, right side, and yeah, this is your back of your head. So on the right is the scan from September last year. So this is your left eye. Right next to the left eye, there was some irregularity. Now this tumor was very close to the nerve, so removing it during surgery would have meant like scraping through the nerves, and it would have caused more problems.
Okay.
And since it is a very low grade tumor, it's essentially a benign tumor, meningioma, which you had on the pathology. It's grade 1 out of 4 grades, and it
Okay.
was a very slow growing tumor. So that's why it was reasonable to leave some behind, because it was not, the hope was it's not going to grow fast.
Right. They were
So-
hoping that it would take years,
Yes.
basically,
yes,
before they would have to do anything else.
Yes.
Yeah.
Yes. Absolutely right. So this was a small area of tumor which was there.
Okay.
Now this is the MRI from last week, and this same area right next to the eyes, it's kind of growing up and down. So if we go up, we see it's kind of pushing onto the nerves here, trying to go into this space which we call the cavernous sinus, where all the veins and blood vessels are.
Okay.
And then also it's kind of going down right below your eyes. So that's why all this area you can see it's puffy, and you can feel it's kind of big there.
Okay.
Now, the idea is, of course, if we had to do a surgery, we would have to remove all of this out, which would mean a really big procedure and a lot of reconstruction and things like that.
All right.
With radiation, we can target this tumor quite accurately, but this is a big area which we are going to be treating. It's not going to be a spot which we are treating, so it's kind of like this big area from above your eye to below. So to our really concern here is we need to get enough dose of radiation to kill this tumor, and at the same time we cannot give too much to cause side effects. So to strike that balance, we have to divide this radiation into a number of treatments. We give you small amounts daily, spread over several weeks of treatment. So for you, we are thinking somewhere around 6 weeks of treatment, which is 5 days a week, Monday through Friday, a total of about 30 treatments or so.
Okay.
So, yeah, as I said, the goal of doing that is to make sure we give small daily doses, your normal body cells can recover, and the tumor does not have that mechanism to recover, so it keeps dying.
Okay.
So that's the hope with this kind of radiation. Otherwise, radiation is just X-rays. The thing we use to treat these tumors is X-rays. Same thing which we do CAT scans with. Your experience remains the same. You're like getting a CAT scan done every day for 6 weeks. Daily treatment time is about 10 to 15 minutes at most. As I said, that's the amount of time you need to be here for. Before we actually start the treatment, the first step is we do a planning session. So this is not like you are going in there, we are turning on the radiation and you're done. No, it's a very customized plan, meaning it's very specific for you, and we cannot treat anyone else or with that kind of plan, and we cannot treat you with someone else's kind of plan. So it's going to be very customized to you. Okay, so the first thing we need to do before that is we need to make sure your head is still during treatment, right? So for those 15 minutes, even if you nod a little, tilt a little, your head's gonna move, and then instead of hitting this tumor, we might hit something else. So we don't want that. The first thing we need to do is to make sure your head is still, and we do that by making this mask for you.
So that's what that is for?
Yes. So it's to immobilize your head during the treatment. So that's our purpose, to kind of hold your head down. It's not tight. It's not like pressing on you or anything.
So it's not gonna be like really claustrophobic.
It's not gonna make you claustrophobic. So as you see these pictures, it has like holes in it. It's just like a plastic mesh. It's like a hockey mask, really, with not metal, but like a soft plastic mask. Okay.
Yeah.
So when we make it, the plan is to do it today, the planning session. So when we make the mask, it's warm and hot, and it's really like you're getting a facial massage.
So it's not like gonna like on your face. It's not gonna like. It's not gonna be like really close to your face. So, like,
it will be touching your face.
it will be okay.
Yes. So it's called a thermoplastic mask because it changes with temperature. So we warm it up really, and then it becomes soft. And when we put it over your face, it really takes the shape of your face. So this is the mask without you, right? So it will be like a mold of you, and you can take it home when you're done. It will be a model of you sitting right next to you. When we start our residencies, they make us make our own masks, so that, I mean, we like to do that. We know how it feels like. And,
Yeah.
So yeah, it's really not too bad. It's like getting a facial massage done. We will make this mask for you, and so you have this swelling in your face, which might go down with radiation because it's 6 weeks. It might increase as well. There is a small chance that there might be some swelling during the treatment. I'll come to the effects and so on. But that might necessitate to make another mask during the treatment itself. Like maybe 2 or 3 weeks later, if that mask is not fitting you well, we might need to make a new one. But that's fine.
It's like 2 masks.
Okay.
You might get more than one, depending on how things goes. But yeah, the first step, as I said, is we make this mask, and with the mask on, we do a CAT scan. All of that is done across the hallway here, right here.
So how long does it take?
So the mask should take, once it's put on your face, it takes about 10-15 minutes to harden, so that it doesn't change its shape once it's removed. So 15 to 20 minutes to make the mask, and then 5 to 10 minutes to do the scan. So really, once you're in there, it's not going to take more than 30 minutes or so. So that's today. And then at the end of the day, we'll give you the entire schedule of 6 weeks for treatments.
Okay.
Typically, it will start about a week to 10 days from now.
Okay.
The radiation itself will start 10 days. Today, you're not going to get any radiation.
Okay.
So these 10 days are really when we are working on your scans. So we are going to use your old MRIs, new MRIs. We'll fuse it to our CAT scan, which we do today. And then what we are going to do is we are going to draw this tumor. We're going to give it a little bit of margin where we think there can be microscopic tumor cells around this area, because sometimes there is actually more than what we see. And then we are going to plan the radiation beams to come in from certain angles so as to hit this tumor and avoid all of your normal brain, the other side, and things in the vicinity, like your eyes, your nerves.
Can you show me how big the tumor actually is?
So it's very irregular. So, I mean, this is one dimension. It's like a couple inches or so right there.
Sorry.
Yeah, no, you're okay.
He hasn't been able to see anything like that. So it's as big as that?
Yeah, so this all is not tumor. There is also muscles around that area, but it's kind of very infiltrative. So that's how meningiomas typically are. Okay. They arise from the lining of the brain. So the brain here is, this all is brain. This all is brain, which is completely normal.
Right.
But then the lining is at the bottom of the brain, and that's where this tumor is starting from. is kind of infiltrating around that lining. So it's difficult to say this is the exact size of the tumor, but it's kind of, yeah, it's kind of big there in this area. So yep.
Why? Okay, if it was a slow growing tumor.
That's a very good question. Sometimes it's very difficult to predict how these things behave. I was gonna ask you, but do you have any family history of
No.
people getting schwannomas or neurofibromas in your family?
What's that mean?
Like anyone else in your family
That's
has
got
had-
NF2.
No.
No.
Okay. So especially when there is a syndromic association, these things can behave not in a typical fashion of slow growth. So that's why we see other small, tiny areas of tumor. Like, so you have one here, you have one here. These are very small, so you can see this one.
Right.
There was one here. So all of them are tiny, really, and it shouldn't. So a lot of people, if we scan 100 people in this building today, maybe 10, 20 of them would have these small, tiny, little grade 1 meningiomas is what we call them, and we don't do anything about it. But just the location of this tumor was really problematic to cause problems with vision. And then it's also been growing pretty fast, so
Yeah.
we do need to address it. And so radiation kills fast growing cells better.
Okay.
So since this tumor is slow growing, we actually have to give a higher dose of radiation, and that's why 6 weeks of treatment is what we are thinking about.
Okay.
So of course, once we, as I said, we'll plan the radiation, and things might change a little bit in terms of the radiation dose, but our goal would be to get this much radiation in there.
Dr. Sloan, his oncologist,
Yeah.
was saying that there could be a possibility he will lose vision in his eye.
That's true. That's true. So the reason why I pulled up this image is radiation is it's precise. We try to be precise, but always at the edges of the tumor there can be some spillover of radiation, and after radiation there can be some swelling in that area, which
Okay.
can affect the things in close surroundings of the tumor. So his eyes and the nerves, not eyes, but the nerves right there, the nerve which carries information from the eyes to the rest of to the brain,
Yes.
is almost encased by the tumor. So that's the nerve, and the tumor is kind of wrapping around it. The reason is the meninges, or the lining of the brain, does wrap around it. So I'm not saying the risk of him losing the vision is going to be super high or anything, but there is a small risk.
Okay. He was also talking to us about, since he has NF2, that radiation can also cause him to have other cancers.
So radiation can cause people to have other cancers even without NF2. That's a known side effect. That's something which pops up years later. So in 10 years, someone has a risk of like 1 in 5,000. So say 0.5% or so
Okay.
is a risk in 10 years. But he has a long life to live. So all that kind of gets added up. So that's the worst side effect from radiation, to get a radiation induced cancer.
Okay.
It's possible. It's more common for kids because you have a long life to live ahead. But unfortunately, that's the necessary evil. And it's not really common. As I said, the risk is 0.5% or less per decade of life.
Okay.
So, yeah.
Okay.
That's very true. So some other side effects, radiation side effects, can be divided into transient ones. Like when you are getting the treatment, there can be some things which can pop in during those 6 weeks or a couple weeks after, and
Okay.
then the late side effects which can pop in months to years later. Okay. So the transient ones are mostly, it's called transient because they go away once the radiation is done.
Okay.
Everything is gradual. Nothing's going to happen on the first day. You're not going to feel anything. I mean, first week, when we do the 6 weeks of radiation, we will see you once a week, probably on a Wednesday or something. So Dr. Palmer will see you and he'll evaluate how everything is going on with you. The first 1 or 2 weeks when you come in, you're gonna say, hey, I don't even think you're doing anything to me. So it's gonna be just like that. You're going in there, lying for 10-15 minutes, and you're done. Towards the end of treatment, so 4th, 5th, 6th week onwards, you may have some of these transient side effects. Most common one is tiredness. So yeah, you may feel a little bit tired more than usual.
Okay.
Second is skin in that region can get a bit red. Okay. So the radiation comes from outside. The skin is always in the path. The skin here gets a little bit of radiation. And some areas are close to the tumor as well. So the skin in this region can get a bit red.
Okay.
It's transient. It does go away within like 2 to 3 weeks after radiation is done.
Okay.
Then along with the skin, your eyes, your conjunctiva can get red. You can have a red eye. You can have watering of the red eye. You can have some pain in your nose because the nose is close to the tumor as well.
Okay.
We'll give you drops and things like that to kind of protect and prevent these problems.
Okay.
But yeah, I mean, even if they happen, they are mostly transient. It's not going to last for a long time. It's
Okay.
going to be typically 2 to 3 weeks after radiation. At the end of the month after radiation, most of these side effects are gone.
Okay.
Hair loss. Okay, so not all your hair, definitely. We are not going to make you lose your hair. But so the areas where the radiation enters from, you can lose hair, which for you, I mean, we cannot predict for sure, but since the tumor is also going into the brain here, the radiation might come in from these directions. So here in this area, you may lose some of them.
Okay.
So
You.
it might just be thinning. But again, it's
Okay.
not permanent. It's just for the duration of those weeks. Okay.
Okay.
I know it doesn't sound great, but
It's okay.
sometimes.
You've had. I mean.
I don't want to go bald.
We had to
Oh,
buzz.
no.
You
Yeah.
won't go bald.
You
And
won't.
we've had to buzz. We had to buzz cut you the last when you had surgery. So
No,
You
you
can.
didn't. Children did.
yes, they want. Yes, but they buzz cut you. So
You can make a good style.
I look
like a
weird.
hairstyle or something.
You'll be fine.
I like this hair.
I know,
Yeah,
but you'll be
they are
alright.
really
And
nice.
it'll grow back.
We'll go back, right?
Yes,
Yep,
it will
yep,
grow back.
They will
Oh,
grow
okay.
back.
I'm fine with it then.
It will grow back. Hair grow back slowly, but yeah.
Never
Most
mind.
of the other things recover much earlier than hair, but yeah, they do grow back in a couple months or so.
Okay.
So all these are transient things. Most of them go away. And then lastly, some swelling in the brain can cause some nausea, some increase in headaches. If that happens, we will give some steroids and to calm down the swelling. Has he been on steroids before, after the surgery or something?
Which hair?
They did have
Like
him
a Decadron?
on an IV steroid
Okay.
for a little bit after his surgery.
Okay.
Remember it was the IV that you had to take at a certain time while
Yeah.
you were still in the hospital.
Yeah.
That's a steroid. It'll help with the swelling.
So yeah, it's a pill which a lot of people take to build their muscles and their
That's what I was thinking.
become stronger.
Yeah, people use it for that too.
So
I read it
no,
for self-harm.
it's a different kind of steroid actually. So the one which I'm talking about, it's the same group of things, but the one I'm talking about, it decreases swelling everywhere in the body. So sometimes, as I said, when we are doing radiation, these tumor cells become irritated and they start to release some chemicals. That's what makes you tired. That's what can cause some swelling in the surroundings, and steroids just take care of those swelling if it happens.
Okay.
They will also help with the nausea if you have any, or if you're throwing up, we can give you medications for that, but
I hate throwing up.
shouldn't really happen. Yeah.
Okay.
Yep.
They can give you medicine too to help it.
Good.
So yeah, these are things. Most of these are transient. The risk of getting them is there about 10% or so. Most of these things, you may have some, you may have more than one of these.
Okay.
Late side effects, things which pop in months to years later, the risk of them happening is really, really low. I mean, mostly it's 1% or less. When we plan this radiation, we have our dose metrics like, oh, we cannot give more than this amount of dose to the eye, we cannot give this amount of dose to the nerves, so we follow those, and when we follow that, the risk has to be less than 5%. Okay.
Okay.
But yeah, as I said, the eye and the nerves are so close to the tumor. We have to really take a call there. Do we save his vision? Absolutely. Or do we leave some tumor around that? So we'll see when we are planning the radiation, and we'll talk to you more. Dr.
Okay.
Palmer will discuss this more as well. But yeah, we'll talk about how much is the risk of causing problems with vision. Okay.
Okay.
And then other late side effects, one of them you already mentioned, second cancers, possible, but months, years, decades later typically. It doesn't happen in few months.
Okay.
The median time of someone to have a second cancer after radiation to the brain is about 8 or 9 years. And that's just the average. Okay.
Okay.
And then other problems like memory, concentration issues, it's gonna be negligible really. That's possibility, but very rare possibility. Whenever we are doing anything to the brain, anything is growing in the brain, it's possible, but that's very, very rare. So yeah. And then are you following with an endocrinologist, or someone is looking at his hormones?
No.
Something. So we probably would want him to see an endocrinologist, because
Okay.
there is this gland called the pituitary gland, which is sitting right in the middle of the brain,
Uh-huh.
and it is actually close to his tumor. So it might get some radiation, and those hormone functions can go down, but it's something which we can easily replace. So
Okay.
yeah, it's usually not much of a problem.
Okay.
I know I've been talking about side effects and effects, but let me tell you, radiation is pretty successful in controlling this meningioma over a long period of time. Of course, it's a local treatment, so we anticipate this meningioma here will be very well controlled. It's
Okay.
not going to do anything to anywhere else, but the risk of this meningioma coming back after radiation is very, very low.
Okay.
So that's the story about radiation. Any questions, concerns so far?
I was wondering about, they talked about some plastic surgery to bring that eye. Will this being gone, will that help that eye to be back up where it needs to be?
So radiation should help with the swelling, and sometimes just when the swelling goes down, the eye can go back up. But if it doesn't happen, or if it worsens over time, they can always do a surgery later. It won't cause problems with surgery.
Okay.
So, yeah.
Cyst in his head went away?
Huh?
What about those cysts in his head? Did those go away?
No, he still has those. He also has cysts from when he had a stroke when he was in the room, is what I was told. But they're still there too, correct?
Yeah, there are some cysts here and there, but yeah, there. That shouldn't be. Yeah, they're tiny, so.
Okay.
Yeah.
Okay.
Is there any paper towels or tissues? Because I got one of those.
Sure. If not, I can get you more. box.
Oh, bet.
Mm-hmm.
I think you covered basically every.
And Dr. Palmer is gonna talk more about all of these things. So
Okay.
we'll have a. I know it's a lot to hear first time, but yeah, we'll get you better soon. Okay.
I thought you were Dr. Palmer.
I'm his resident. I'm still in training. So yeah. Yep. If you guys are okay, I would like to go ahead with the consent and read it for you. So,
Okay.
Jason, Dr. Palmer is going to treat your meningioma with partial brain radiation, meaning radiation only to the tumor. Uh, cannot promise this would cure or improve your condition, but we are pretty confident treating this. These are the risks listed: fatigue, skin reaction, loss of hair, and then all these things with the possible word next to it are very uncommon. So,
Okay.
possible difficulty in concentration, fullness in the ears, nausea, vomiting, headache, brain swelling, hearing loss. I don't think so. He's gonna have hearing problems with this, but loss of vision, yes. Decreased hormone levels, needing replacement, and then damage to brainstem, spinal cord, loss of strength in extremities is almost impossible because the tumor is not close to those areas of the brain.
Okay.
Possible cataracts in the left eye, yes, but it's again something which can be easily fixed.
Okay.
And then we have talked about these problems. If you have any questions, you can always ask them. We talked about alternative treatments. His surgery is not a very good option here. We don't need to put him to sleep. He doesn't need any blood products, and he does not have any electronic devices in you, right?
No.
Okay.
I have a phone.
It's not inside of you, right?
Oh,
Well, sometimes I feel the phone is inside of me, but that's all. If you don't have any other questions, if you could go ahead and sign it. You can sign it as well, and then Mom can sign it
where do I sign it at?
right there. The first one. Yep.
Are they teaching cursive yet?
Well, he's doing a good job.
Anybody don't remember first and last name?
They only really teach them to do their name anymore.
Okay. There you go.
Great job.
Do I put just Mom?
Yeah, you can just put Mom in brackets. Yeah, works.
Today's
7/12.
It is 8:54.
Yeah.
8:54.
Uh-huh.
So. Right. Do you mind if I do a quick exam, listen to your heart and lungs?